All right, focal seizures, there's something I want to clarify. So we have two broad classifications on seizures. We've got the generalized and we've got the focal. Generalized happens in both sides of the brain. It affects the entire brain, whereas focal starts at a focal point. It may spread to other parts of the brain, but doesn't necessarily have to. So make sure you're aware of the difference there. It may spread, but not always. Focal seizures, again, may be precipitated by numbness or tingling. And then they're divided further according to their clinical manifestations into either a simple focal or a complex focal. And that algorithm that is in your textbook that I showed you on a previous slide, that breaks that down into the various classifications. So in the simple focus, the patient remains conscious and alert, but they'll probably experience unusual feelings or sensations that could take on many different forms or many different emotions. They may also hear, smell, taste, or see, or feel things that aren't there. In the complex, the patient loses consciousness or an alteration in awareness. Their eyes are open, but they're not able to answer questions or interact with somebody else. They may display strange, repetitive behaviors, and then they're not going to remember anything that they did during the seizure. These seizures can last from anywhere from 30 seconds to 2 minutes. And again, the patient is going to be really tired after the seizure and may not return to normal activity for a period of time. Another focal seizure, the tonic-clonic, is preceded by an aura or a warning that the seizure is coming on. A secondary generalized seizure may result in residual neuro problems, like Todd's paralysis. Your book mentions that. So the focal seizure, again, it may be confined to one side of the brain and remain focal or partial. However, they may spread and affect the entire brain, culminating in a generalized tonic-clonic seizure. But any tonic-clonic seizure that starts by an aura or a warning is a focal seizure that generalizes as a secondary issue. So a little bit confusing there, but I think if you look at this algorithm, just be familiar with that. That breaks it down pretty well. And just a little bit more on Todd's paralysis. That's like focal weakness. That's like one area of weakness that will resolve, but it, in varying lengths of time, no specific time for resolution on that. The focal seizures may be misdiagnosed as epilepsy because they look very much like an epileptic seizure. In order to get a accurate diagnosis, we'll need an EEG monitoring, a video EEG monitor to identify the events surrounding the seizure. If the diagnosis of epilepsy is excluded, we'll look at the history of emotional or physical abuse, or maybe some specific traumatic event that we find out that may be triggering these things. And some patients may have, a variety of different issues that are causing this. Status epilepticus is defined as any seizure that lasts longer than 5 minutes. Longer than 5 minutes, that is a long time for seizure activity to occur. This is a neurologic emergency, and this can actually occur in any type of seizure. This is going to require a medical intervention. The highest incidence of status epilepticus occurs in children and older adults. But basically what's happening is seizure activity, or a condition where where many seizures occur in rapid sequence. So they're just seizing over and over and over again. It's the most serious complication of epilepsy. Status epilepticus can cause the brain, or will cause the brain, to use more energy than what it's able to supply. And so the neurons become exhausted and they're not able to function any longer. So your neurons are your nerve cells, and they're just worn out from this activity and they stop functioning. Permanent brain damage can result from status epilepticus. So again, this is an emergency that will require medical intervention. Some of the nursing considerations for any kind of seizure. I mean, this says status epilepticus, but any time you have a patient who has a chance of seizing, or, he's got a history of seizures, or he's got some type of condition that may precipitate a seizure, there's some nursing considerations. For one thing, we want to pad the side rails. This may be just wrapping blankets around the rails and taping them, or your facility may have, special pads that are applied. We'll want to make sure, of course, there's going to be oxygen in the room. It's on the, it's already on the wall of every room in the hospital, but make sure that the nasal tube or the tubing is in there. And then have suction available. We're not going to be suctioning during a seizure, but after the seizure, we may need to suction. We never want to try to restrain a patient or hold them back or put anything in their mouth, to hold back the tongue. That just makes it worse. But after the seizure, we're going to perform, of course, we're going to determine if there's any injuries. We're going to suction as needed, apply oxygen as needed. So back to status epilepticus. Again, it is the most dangerous, and it can cause ventilatory insufficiency, hypoxemia, cardiac dysrhythmias, hyperthermia, systemic acidosis. This can be fatal. Severe injury and even death can occur during a seizure. The patients that lose consciousness are at the greatest risk. People with epilepsy have a mortality rate 2 to 3 times the rate of the general population. So this is something that should be taken very serious. SUDEP is sudden, unexplained, or unexpected death in epilepsy. That's what that stands for. And SUDEP is higher in males and people that have to take multiple anti-seizure drugs, as well as people that have had epilepsy for a long time and have had poorly managed seizure activity. So the effects on a person's lifestyle is the most common complication of seizure disorder. Depression is common. There may be a social stigma because, people think that, you're some kind of a freak because you have seizures. You may be discriminated against in employment, and you're unable to drive a car if you have seizures. So I can remember back in grade school, there was a boy in my class that would have, the tonic-clonic type of seizures. And we'd be out at the playground. It's usually when it happened, but he would, fall to the ground. He would be rolling around, drooling. His eyes would roll back in his head. And it was very frightening for, the rest of us children that had no idea what was going on. And it was also frightening that the teachers would just watch them. They didn't, try to stop it. And so it was hard to understand. And after the first seizure that occurred, my teacher, I can remember him always asking the student, did you take your medication? Did you take your medication? Because seizures can be controlled with medication. So it's important that patients are in compliance with their medical regimen. And there are a list of drugs in your book for seizure disorders and epilepsy. There's several different drugs that can be used. So what should you do if your patient has an uncontrolled seizure, but he insists on driving, even though it's against the law in your state under these health circumstances? So how would you handle that? What would be your responsibility? I think that educating the patient as much as possible and letting them know what the risks are, that they could kill someone else along with themselves. They could end up in jail or losing their license. So I think you're really going to have to step in and get very serious with these patients. So in this case study, 54-year-old WL reports experiencing periods of feeling suddenly disoriented. He wasn't aware when this was happening. His co-workers told him that on several occasions he was observed behaving inappropriately. His behavior consisted of lip smacking, facial grimacing, which would last a couple of minutes, and then he would act disoriented and confused. He was afraid he might have Alzheimer's disease, so he scheduled an appointment with the neurologist. What kind of seizures is he likely to be experiencing? Well, this would be probably a complex focal seizure. So if you recall, in the complex focal seizure, the patients lose consciousness or have an alteration in their conscious, and they're kind of in a dreamlike state. And this is where they may have lip smacking or repetitive motions. So this is probably a complex focal seizure. So diagnostic studies of seizures, an EEG, history, of course, all the information we can. Is it in the families? Different tests that can be done. CBC, serum chemistries, liver and kidney function. We want to do a UA to rule out metabolic disorders. So that's just a couple of the tests. The magnetoencephalography in conjunction with the EEG. The magnetoencephalography may be done with the EEG because it has greater sensitivity in detecting small magnetic fields that are generated by neuronal activity. So there are some tests that can be done along with clinical history. We may do a CT or MRI if it's a new onset of seizures to make sure there's not some kind of a tumor there. Cerebral angiography, looking at the vessels, various tests your textbook talks about that can be done to find abnormalities. Most seizures don't require emergency medical care and are usually short, self-limiting, and they don't, very often cause bodily injury. But please remember that it is an emergency if the patient is in status epilepticus. So again, greater than 5 minutes. This patient just keeps seizing over and over again because there is significant bodily harm that can occur, brain injury, and also if it is a first-time seizure, that is definitely something that we need to seek medical care for to find out why that happened. So primarily seizure activity will be treated with anti-seizure drugs, and the goal is to prevent seizures with the minimal amount of toxicities from the drugs themselves. Cure is not possible. The drugs stabilize the nerve cells and prevent the spread of the epileptic discharge. About a third of the patients are going to need more than one drug. Some of the drugs will need to have levels checked periodically, but the newer drugs typically do not. drugs need to, for